Hi, I am Dr. Vidhu. Today we will discuss acute disseminated encephalomyelitis. It is an acute demyelinating disorder of central nervous system. So it is one of the demyelinating syndromes in childhood. As the name suggests, it is acute in onset. As the lesion is disseminated in the central nervous system, we have polyfocal neurological deficits, along with encephalopathy. Next, the International Paediatric Multiple Sclerosis Society group have framed the diagnostic criteria for this ADAM. This diagnostic criteria was first formed in the year of 2007. Next, they have revised in the year of 2013. That is not that much necessary for you guys. So what is this diagnostic criteria includes? First point, it is a polyfocal neurological deficits. Second, encephalopathy. Third, imaging. In imaging, brain MRI should be consistent with the demyelinating features. Fourth, there should not be any new clinical or radiological features after 3 months from the initial onset of illness. So these are the diagnostic criteria for a child to be diagnosed with acute disseminated encephalomyelitis. First is there should be a polyfocal neurological deficit. Second, there should be encephalopathy. Third, imaging should be consistent with demyelination. Fourth, there should not be any new clinical or radiological features after 3 months from the initial onset of illness. Second, this will mean age group. So what is the mean age group it affects? According to ijpp, it is between 3.5 to 7 years. And according to Nelson, it is between 5 to 8 years. They have male predominance. Okay. Third point, the etiology. This ADAM is mostly associated with viral infections. So viral infections are preceded by ADAM. So what are the viral infections? Influenza, CMV, HSV, enterovirus, varicella, measles, mumps, and rubella. Certain vaccinations can also trigger ADAM or associated with ADAM. These are influenza vaccination, second varicella, third DPT, MMR vaccine, polio vaccine. Okay, this is the point you have to write it as a third point in etiology. Next, we'll see on with pathophysiology. So pathophysiology for this ADAM is unclear, but the hypothesis states it can be associated with molecular mimicry. So the antibodies that are elicited against these viral infections attack the attack the MOG antibody that stimulates the inflammatory cascade, and that leads on to demyelination. So the antibodies elicited after the infections, they form anti-mock antibodies. This stimulates inflammatory cascade that leads on to demyelination. So this is the pathophysiology in Adam. Next, the Adam, it comes under the group called ADS. So what is ADS? It is an acquired demyelinating syndromes. This acquired demyelinating syndrome is classified as monophasic, second as recurrence. Under monophasic, we have Adam, second optic neuritis, third transverse myelitis, fourth clinically isolated syndrome. Under recurrence, we have MOG associated demyelination. So MOG is myelin oligodendrocyte glycoprotein associated demyelination. Next is neuromyelitis optica spectrum disorder. Third, multiple sclerosis. This is an additional point. If you want, you can remember or you can write it in your examination. Next, fifth point you have to write in Adam is clinical manifestations. So in clinical manifestations, first there are non-specific prodromal symptoms. So what are the non-specific prodromal symptoms? There will be fever and headache, vomiting, or you can call it as flu-like illness for about 3 to 4 days. Next, this is followed by the signs of encephalopathy. The neurological sign depends upon the site in which the lesion is getting affected. So this encephalopathy is an hallmark of Adam. So encephalopathy is an hallmark of Adam. That one you have to remember. This encephalopathy, this can range from behavioral disturbance to coma. Next, the common neurological signs. So the common neurological signs can be visual loss or diminution of vision, cranial nerve palsies, cerebellar signs such as ataxia and nystagmus. Fourth, there can be motor and sensory deficits. These neurological signs or maximum deficits are usually seen within 2 to 5 days. So maximum deficits are manifested within 2 to 5 days. Okay. Next, appearance. If there is an appearance of a new clinical sign or a radiological feature, it is considered as second event that should occur after 3 months from the initial onset. Okay. That is the next point. This is the clinical manifestations. Next is appearance of new clinical or radiological feature after 3 months from initial onset, it is considered as second event. Okay. Retrospectively, they have classified ADAM. So next is, sixth point. Classification. First is monophasic ADAM. So what is monophasic ADAM? It is a single event without any recurrence. Second is multiphasic ADAM. There is no term called recurrence ADAM. It is multiphasic ADAM. That is second event with encephalopathy. Second event with encephalopathy or any neurological findings in the MRI, that is radiological findings, is called as multiphasic ADAM. It should be 3 months beyond the initial event. Third one is ADAM with optic neuritis. So that is monophasic or multiphasic ADAM with one or more episode of optic neuritis. One or more episode of optic neuritis comes under ADAM with optic neuritis. Fourth, it is acute hemorrhagic leukoencephalitis. So acute hemorrhagic leukoencephalitis, AHLE. Okay. There will be a in the radiological finding, there will be a multiple hemorrhages with necrosis along with demyelination. This is characteristic finding in acute hemorrhagic leukoencephalitis. They have a grave prognosis. Okay. So these are the class. This is the sixth point, that is classification of ADAM. Next, seventh point, diagnosis or the diagnosis. Now we are going to diagnose. So this ADAM is mostly a diagnosis of exclusion. Okay. Then what are diagnosis of exclusion is what all you have to exclude. That is a differential diagnosis. First, infectious meningoencephalitis. Second, intoxication. Third, CNS vasculitis. Fourth, CNS malignancy. Fifth, leukodystrophies. Okay. So what are the investigations you will do? First is neuroimaging. So you have to do a contrast enhanced MRI of brain with optic nerve cuts and spinal cord. So what finding you will see in this are multifocal, it's a contrast enhanced. So there will be a multifocal, large, ill-defined lesion, which will be a T2 hyperintense in the white matter with or without gray matter or brainstem involvement. This is neuroimaging first. Second one is CSF studies. It is mainly done to rule out other DDs. So to rule out other differential diagnosis. It is non-specific for Adam. So but in Adam you can see lymphocytic pleocytosis. Second, there will be an elevated protein. Third, there can be oligoclonal blunts. Third investigation is specific serum antibody testing. In specific serum antibody testing, you have anti-MOG antibody. Second, anti-aquaporin 4. So this is for diagnosis of mainly for MOG associated demyelination. Okay. Next, histopathology, but this is very rarely required. It is mainly done to rule out CNS malignancy. So what are the findings you see in Adam is there will be a perivenous demyelination with inflammatory infiltrate. So these are the investigations. That is, first you do neuroimaging. It is contrast enhanced MRI brain. Second, CSF studies. Third, specific serum antibody testing. Fourth is histopathology, which is rarely required. Okay. Next, treatment. So the treatment will be your 8th point, right? So treatment should be supportive. Next is specific. Third, there should be a rehabilitative. Supportive measures such as there should be an airway protection. Second, seizure control. Third, fluid and electrolyte balance. Next is the specific. So what are the specific therapy? Is specific immunomodulator therapies. So treatment of choice. So treatment of choice is pulse methyl prednisolone. That is 20 to 30 mg per kg per day for 3 to 5 days. This is followed by oral steroids, which is tapered in the dose of over 4 to 6 weeks. This is the treatment of choice. If this is not working, then you can try on with IVIG or plasmapheresis. For fulminant Adam. So what is fulminant Adam? that is, it is not responding to steroids, IVIG or plasmapheresis, is called fulminant ADEM. In this case, you can use cyclophosphamide. Okay, that's all about acute disseminated encephalomyelitis. Thank you. Have a nice day.